Significantly today, we are here for chapter for GLC4HSR, the Global Learning Collaborative for Health Systems Resilience. Amongst our members, technical advisory group, colleagues, friends, academic partners, and of course, all of us who are present here today to significantly take on the next level of our work in growing the global learning collaborative for health systems resilience. A warm welcome to each of you, afternoon, evening, and morning from wherever you are joining. We embark on this significant occasion towards growing the presence of the learning collaborative. I'd like to quote from a WHO study conducted in 2009 titled Primary Healthcare in Sri Lanka, a Case Study. It resonates with the enduring commitment of Sri Lanka to unveil universal healthcare dating back to 1950s when the nation introduced a pioneering free healthcare system. Over the years, this system expanded to encompass both preventive and curative services. And in 1978, Sri Lanka was amongst the first countries worldwide to adopt a primary healthcare approach. This chapter is unique. It is championed by the Medical Services and Primary Healthcare Services Ministry of Health, Sri Lanka. And we are fortunate to welcome the DG of Health Services, Ministry of Health, Sri Lanka, to this occasion. Amidst various challenges from non-communicable diseases and the impacts of climate change, Sri Lanka has made remarkable strides in strengthening its primary health care. Notably are some numbers: life expectancy, 75.2 years to 77 years in 2021, and infant mortality brought down from 10.2% for 1,000 lives births to 7.8 in the same period. Similarly, maternal mortality has seen a substantial decline, 36 per 100,000 live births in 2015 to 24 in 2021. This is a significant achievement and even more remarkable in the fact that Sri Lanka has been on the receiving end of many disasters in the recent years, along with the economic crisis that directly impacted the healthcare provision. I had the privilege of being there a month ago to witness what they have done for their primary healthcare across the country. Indeed, a proud moment. Sri Lanka's dedication to a robust primary healthcare system has been a lifeline of its people. Country chapters of the GLC4HSR, which is a learning journey, is going to be another addition to their real support in the primary healthcare area towards facing challenges and resilience. This Global Learning Collaborative is a bottoms-up approach, a learning journey that facilitates the exchange of knowledge and experience between local and global healthcare system, along with its resilience in building experiences amidst natural disasters, socioeconomic crisis, health crisis can provide valuable insights for us to take across the various chapters. We are committed to fostering a culture of mutual learning, building partnerships that will strengthen the health systems and elevate the health of the people across the nations. As we inaugurate this chapter, it's a proud moment today. We will engage with all the esteemed speakers in a fruitful discussion and leave some time for question and answers as and when necessary. I invite Dr. Krishna Reddy Nallamalla to provide the overview of the Global Learning Collaborative for Health Systems Resilience and set the stage for today's launch. Briefly to introduce Dr. Reddy, who doesn't need any introduction, he's a practicing senior cardiologist, president of Access Health International in Asia, and also the president of InOrder, in the Health Systems Training Institute, set up as an associate of Access Health. His illustrious career, he has founded many enterprises with a mission to evolve models of high-quality healthcare that are affordable and accessible. Amongst his many achievements is the realization of the India's first coronary stent collaboration with Dr. APJ Kalam, then the chief of DRDO, in order to create an indigenous technology platform for medical devices and make them affordable. So the Make in India started with Dr. Reddy many years ago. Dr. Reddy joined Access Health International in 2018 to lead the health system strengthening efforts in this country and beyond. I hand it over to you, Dr. Reddy. And DG sir, please do bear with us. We will take a little bit of your time today. Thank you. Thank you, Dr. Reddy.
Yeah, thanks, Uma, and hearty welcome to the Sri Lanka team, esteemed senior leadership of the Sri Lanka Health Ministry, and also my esteemed colleagues, members. We also have our advisors of the Global Learning Collaborative. Many of you are aware of it, Global Learning Collaborative, but I noticed that many of you are also newly joining this family, growing family of the Learning Collaborative. The key objective of establishing this collaborative was to leverage the strength of the joint learning of different stakeholders of the health systems, be it researchers, practitioners, civil society, the policymakers, the industry, the private sector. The idea is to get the perspectives of the different stakeholders to take up some of the thematic areas of health systems, learn from each other to solve some of the problems and to translate some of these insights into policies or trends or operational plans that will contribute to the strengthening of health systems and make them more secure against the growing threat of the different threats emerging from the climate change, the pandemics, the geopolitics, the economic crisis, and also make the health systems more resilient. That was the founding objective. That means the collaborative learning to insights, and from insights into actions. I mean, actions that make impact on the health systems. As a part of that, Access Health has been playing the role of the Secretariat. However, the family of this collaborative has been growing organically over the last 1.5 years and 2 years nearly. To reach this stage of 80+ members and 12 technical advisors from 25+ countries, truly it has been a great journey in the last 1.5 years. Ever since it was launched on March 11th, incidentally, March 11th was the date on which the pandemic was declared by the WHO in 2020. Briefly, I mean, in the journey, we have evolved into taking up the thematic learning journeys around the core 8 themes of the health systems. I mean, this model emerged out of the deliberations of different members as to what are the gaps in the existing models and the frameworks to express the resilience in a more authentic way. This 8 thematic areas starts with the people in the center, understanding people, their health status, the determinants of the health status, and also the emerging threats to this health of the people. and what people actually can do to become themselves resilient, that is the community resilience, whether it in terms of the literacy, in terms of participation in the governance, in terms of the engaging the health systems and other social systems. So the people element, the thematic area element itself has become one of the core focus thematic area. In addition to the four functional that actually drive the health systems in terms of providing the healthcare, the supplying the needed health goods, financing both on the supply side as well as the demand side, and importantly, the governing of these complex dynamic health systems. In addition to these four core functions, the three cross-cutting functions also emerged as the focus thematic areas of the health system, which includes the information flowing across the health systems, both horizontally as well as vertically, and the communication, most important communication in terms of how communication can integrate and coordinate and harmonize these complex dynamic health systems. And the relationships between the different actors in the health systems, because it's not just the government regulating the health system, but many actors have emerged who have an impact on the health systems. So there has to be a good, deep relationship horizontally within the ministries, between the different sectors, different ministries, vertically between the nations, between the regions, between the center and the state. So this is how the thematic work the GLC has been taking up in the last few months. And there have been thematic focus groups who expressed interest to work around each thematic area so that some of the deeper insights come out of each thematic area. As a part of that, one of the thematic area that has gained momentum has been around strengthening the assessment, monitoring, and surveillance systems. Because any systems, unless these are put in place, and the systems have the capacity and ongoing competency to have a robust assessment of the health of the people and the health status of the health systems and their performance. And in addition, a deeper surveillance of the diseases and their emergence and their growth pattern. So these surveillance and health systems assessment have been the key focus areas, and we have advanced significantly to a level where 5 countries, including Sri Lanka, which will be joining the family as a chapter, a country chapter today, will be taking up the assessment of the health systems in each of these countries. And also it enables by engaging people from bottom up as well as from the top down as to how they can build capacity to assess their own health systems, monitor their own health systems on an ongoing basis using a standardized tool. So that is, I think, one of the key output of the GLC with help of the collaborative learning. The second thing, as a part of that, the recent workshop in Bangalore, that along with the Tata Institute for Genetics and Society, that brought out a lot of insights and also some understanding that we have to bring out a blueprint in terms of what should be the future-ready surveillance, alert, and response systems to face any public health emergency in the future. So that is, I think, is an important journey in the area of surveillance, not only the surveillance, but how to enable rapid alert systems and the response systems by integrating some of the new age technologies of digital technologies as well as the molecular technologies. So that's an important thematic area that has come out of it. The third thematic area that has been gaining momentum is with reference to the threat of climate change. So already a webinar series has been conducted, and also there is an upcoming off-day workshop as a part of the CHISTI's PSC forum in Indonesia with reference to the climate change, its impact on the people and their health, and how people are trying to adopt, and they can be empowered to adopt to the climate change with reference to securing their health. And more importantly, how health systems have to prepare themselves for the emerging as well as unknown impacts of the climate change in future. So that is the third thematic focus area that has emerged in the and gaining momentum in the. Similar to that, there have been some momentum in the area of the governance, in the area of supply chain resilience, as well as in the area of the provider system preparedness, especially the PSC forum conducted by the WHO CRO. Recently, it was held in Sri Lanka itself, and also the PSC forum being conducted by CHISTI in Indonesia, positioning the PSC as the key anchor of the preparedness of the provider system for future public health emergencies. So I think we used to describe this journey as a river, and the rivulets joining to form a bigger and bigger river around the themes to ultimately achieve that final impact of health for all. I think that's the ongoing journey. I think it's more important to enjoy this collaborative learning journey with the hope that some of these insights will be taken up by the policymakers, by the strategists, by the operational planners into impact creating actions in different geographies. Just as the GLC is getting organized around the themes, it is also getting organized around the levels of health systems. It is not just enough to think from a high level of global health perspective, because most of the policies and the insights come from the high level global health systems. But idea is to evaluate health systems and create these learning collaboratives and address some of the challenges unique to different levels of health systems. Because the challenges at the global health level, where it is the transnational issues which matter, are different from the national levels, the regional levels, the subnational levels, and going down to the local levels, the local governance levels. So that is the second approach to organizing the GLC around the levels of health systems, organizing around the stakeholders, whether it is private sector or the public sector, researchers or the practitioners, and organizing around the themes. So this has been the brief, I think, summary of the GLC and update on what is its objective, how it is getting organized, and what has been its journey in the last 2 years. And we intend to enjoy this journey as we go forward, with more and more people joining, either as members, as advisors, as technical facilitators, as technical coordinators, or people attempting to pilot some of the actionable insights, like assessing the health system's resilience in 5 countries. I think with this brief update, I again thank each one of you, and also welcome all of you to join this momentum and the GLC as we go forward. And especially our sincere welcome to the people from Sri Lanka, because Sri Lanka will be our newest member as a country chapter. India is the one country chapter. The Bangladesh joined recently. Sri Lanka will be the 3rd country chapter, and we are hoping Indonesia will have a formal launch in the upcoming PSC forum on 13th and 14th in Jakarta. So that will become the 4th country chapter. So idea is to bring countries so that the country chapters slowly evolve themselves, address the context which are important to their chapter countries, because they will understand the challenges and the problems of that countries. And the same culture of this learning collaborative will hopefully find solutions that can be taken up by the policymakers in each of these countries. Thanks again. Over to you, Uma, for taking up the next part of the agenda.
Thank you, Dr. Reddy. It's always interesting to hear this journey as many times as we have, because every time there's an additional growth that we take forward, and every time there is additional learnings that we have learned when we travel this journey. It is my proud moment and honor to introduce Dr. Asela Gunawardena. whose life and career are truly inspiring. Dr. Gunawardena holds extensive knowledge of the health sector since his career began at the grassroots levels, where he developed the most needed skills in rising up to the prestigious position as the Director General of Health Services. He has worked in several health settings, such as as District Medical Officer for Maternal and Child Health, Regional Malaria Officer, Regional Director for Health Services, Director for Teaching Hospitals, amongst others. He entered the University of Paradena in 1984 as a medical student and started his medical profession as a District Medical Officer in Badal, Kumbura in 1994. An avid footballer, and also balanced his play while he actually worked as hard as he did. With a master's degree and a doctoral degree in medical administration, he's also competent to take forward the services as he does. He's also a master's degree in Buddhist studies and business administration, as currently he's studying his PhD in Buddhist studies. And if you do visit Sri Lanka, you will know how much importance they give to these studies that actually are so deep-rooted in their culture. He has won many international and national productivity awards on many occasions. He's the most senior medical administrator and has experience both in preventive and curative health sectors. He has been developing the health systems and institutions using this experience, skill, and training. Indeed, an inspiration to many of us, including those that are lucky to be led by him in Sri Lanka. With his address, we will formally announce the inauguration of the Sri Lanka chapter. Post his address, I would request everybody to come on camera for us to capture that moment. Thank you so much. Over to you, Dr. Gunawardena.
Good evening. Thank you very much for your very kind introduction. I think Dr. Samartha has given that details to you. So thank you very much again. And with me, I would like to introduce Dr. Lar Panapitiya. He's the Deputy Director General Medical Service 1. And there are Dr. Samartha Ranasinghe, your good friend, the Director of Primary Healthcare. And here Dr. Priyantha Karunaratna, he is the Director of Medical Service. And Dr. Priyantha Adapattu, he is Director Tertiary Care, who is in charge of the tertiary care. So there are 3 Priyanthas here, 1, 2, 3. So thank you very much, and Dr. Reddy and all the other distinguished faculty in your part, and giving this opportunity for Sri Lanka to join your esteemed faculty. And thank you very much for giving that opportunity. So I think my topic is to speak on primary health care. So as all of us know, Sri Lanka is having a free healthcare system, which includes broadly divided, that is preventive and curative. Curative is the hospital sector. Preventive is the medical officer of health, where all immunization and maternal health and child health are after. And we have 2 other sectors, that is institutions belong to the central government and institutions belong to the provincial level. So primary healthcare is the actually the backbone of our healthcare system, which is a key to achieve universal health coverage of our country, and which is we are expected 2030, and to achieve the sustainable development goal. So development of primary healthcare system, actually we have a very good primary healthcare healthcare system, but we are going to strengthen that to achieve the universal health coverage as well as the SDG goal 3. That is our ultimate target. So, with me, all our team members are working towards that, and we have a very strong primary healthcare system. That's why even with our economic downturn, we are still surviving and we are still continuing our health system. So, strengthening the primary healthcare system will ease the burden of secondary and tertiary care system as well. So, the needy patients who are in secondary and tertiary care centers will get the needy care because it is reducing the overcrowding of secondary and tertiary care system. And we will be referring back the patients to the primary care system to the follow-up for their clinic visits as well as for their continuation of their medication. So that system is actually linked with the primary medical care institution, that is about 1,100 institutions are there throughout the island, as well as it is linked with the preventive center with medical health officers in 354. So this is the integration of preventive, curative, as well as rehabilitative, geriatric, palliative, as well. So our aim is to combine all these sectors into one place where the people who are in the villages can get their treatment as well as the other facilities in their convenient place. We all know that our most convenient place is the home. So as well as the hospital at your village level is the most convenient place. So our aim is to develop that place and link that place to the secondary and tertiary care system through these telemedicine facilities. So that is of one of our main concern, and actually it will, I think, explained by Dr. Lalpana as well as Dr. Samantha in their speeches. So as the DGHS, what I am doing is I am doing the collaborative work with all these my directors and the DDGs, as well as the provincial and the provincial authorities where they are working in the peripheries. So this is in a nutshell in private healthcare system. I think the respective speakers will elaborate on this subject further. So I would like to thank again for your access in Health International Asia for giving this opportunity for the Global Learning Collaborative for Health System Resilience. And Dr. Reddy as well as Dr. Uma, thank you very much giving this opportunity, and we hope that we will be able to work with all of you and share our experiences with you and get your experience as well, and to develop our system as well further to give the best possible care for the people of this country. So thank you very much, and have a very productive day. Thank you.
Thank you, Dr. Gunawardena. Can we have everybody on video, please, so that we can take the photograph of the launch, the formal launch? Can the Sri Lanka team stand together so that we have them all together? What a privilege. Please take those photographs as something, as one more milestone in the Global Learning Collaborative. Thank you, the team at Sri Lanka, for officiating this launch. So I have now the proud privilege of again introducing somebody who has been instrumental in making this journey happen and for us to be able to have the Global Learning Collaborative as a country chapter. Dr. Lal Panapatya, the president of the College of Medical Administrators of Sri Lanka. His theme of presidential period is rising through the challenges towards health systems resilience. And it so echoes with what we are doing today. The Global Learning Collaborative is one more addition to what Dr. Panapatya is going to take forward as his presidential period. He's a consultant in the medical administration, member of the Board of Studies of Medical Administration, Postgraduate Institute of Medicine, University of Colombo, Sri Lanka. He's also the Deputy Director General of Medical Services, responsible for governing the secondary and tertiary care in the services of Sri Lanka, and responsible for the Consultants Administration pre-intern appointments. If you meet him, you will know how humble he is for all that he holds and does. I hand it over to Dr. Panapatya, who has been part of this journey for more than a year with us now, and with whose initiation Dr. Samantha and Dr. Panapatya have led this chapter launch. Over to you, Dr.
Thank you, Dr. Uma. Very good evening to all of you. Dr. Asela Gunawardena, Director General of Health Services, Ministry of Health, Sri Lanka, and Dr. Samantha Ranasinghe, Director Primary Healthcare Services, and Dr. Priyantha Athapattu, Director Tertiary Care, and Dr. Priyantha Karunatha, Director Medical Services in the Ministry of Health, and others actually that were willing to join with us today, but unfortunately today is a working day this time. So then they have engaged in many activities. So then they couldn't participate. That's why few of us are here today. And Dr. Reddy, the President, Access Health International Asia, and all office bearers, including Dr. Uma and others, and members of Global Learning Collaborative for Health System Resilience, and all the representatives who are joining from other countries with us today. It is our great pleasure to join with you and all at the inauguration of Global Learning Collaborative for Health System Resilience, Sri Lankan Chapter. Today, hoping to develop our health system more resilient through the networking with you all, sharing our experience and collaborating with others. Being a strange experience to the whole world, the COVID pandemic emphasized to the world the critical importance of resilience that transcends geographical boundaries and directed all countries to make their health system better prepared for resilience in order to withstand and respond against all forms of threats. Also demonstrated the need for better collaboration and coordination across borders and other sectors, that means beyond boundaries, as well as the significance of medical administration and medical leadership also. Resilience focuses for securing health for all, assuring universal health coverage, and achieving the health-related sustainable development goals. Due to the frequent new challenges among the routine challenges such as economic uncertainty, changing geopolitics, global warming, other than the pandemic, national leaders and policymakers had to make their system resilient to face these challenges as their number one priority and responsibility while all other planned developments. Similarly, it was strange, but Sri Lankan health system was able to face the pandemic successfully while maintaining its routine healthcare services both in preventive and curative aspects. This resilience was evidenced not only during the crisis of COVID pandemic, but also in the face of other recent challenges such as civil war, tsunami, and recent economic crisis and others. Hence, crisis and resilience are not uncommon to Sri Lankan health system. This was made possible due to the presence of well-established healthcare system, which was achieved numerous milestones with excellent health indicators, offering specialized and doorstep services to individuals by healthcare professionals. Though it is mainly contributed by Western allopathic system, but also the contribution of all other health systems prevailing in the country could not be disregarded. Strategies what we have adopted by Ministry of Health for health system resilience will help to develop preparedness of a system, enhancing capacity to respond to a shock through absorbing, adopting, and even transforming based on lessons learned from the past and present experiences. Most importantly, maintaining provision of critical functions and essential services even within a crisis, as well as focusing to deliver high quality care service across varying conditions. Those have been developed based on the health system building blocks identified by WHO, such as improved safe, quality, productive, customer-focused service delivery, improved access to essential medical products, strengthening health workforce and health information system, and also sustainable health system financing is utmost important, especially in such a crisis situation as we are facing now. When we achieve all this, it will ensure the social justice and equity, as well as community engagement and empowerment. Success of all these strategies require empowered visionary leadership with shared vision. Responsibility of leaders is to achieve the good governance and directing all stakeholders in a common goal. With the lessons learned during the past experience of COVID and other crises, including innovative solutions such as home-based care with a call center facility, step-down centers which still be practiced, could still be practiced for betterment of health service. It has been proposed and planned many interventions for further resilience of the system, such as establishing regional isolation centers through regional disaster management plans, strengthening emergency unit focus for CBRNE, as well as strengthening primary healthcare services with telemedicine facilities, as well as developing and strengthening of health staff, and furthermore, not only the interventions by Ministry of Health, our College of Medical Administrators, the esteemed college actually for the medical administrators in Sri Lanka, has identified its theme for this year 2023 as rising through challenges leading towards health system resilience beyond boundaries. And all the academic sessions and other activities were done based on above identified strategies for health system resilience. These activities not only for awareness, but also for motivating, inspiring, and strengthening leadership of our members. Global Learning Collaborative for Health System Resilience was an inspiration for us to attend on all these activities. Resilience means not just withstanding shocks, but also adapting and even transforming to better state better than earlier in response to change. It is always a good opportunity for a good leader to create a new future. So we invite and insist on all of you to think differently, act differently, and achieve differently towards a common goal, one world, one health. Thank you.
Thank you, Dr. Panapatya. Indeed, lots of thought-provoking ideas that you have put together, and also sharing of experiences that we have heard from you. The spirit behind this collaborative and this country chapter is Dr. Samantha Ranasinghe. He has his other initials which say GSP, but I think he's very endearing to us and is known to everybody as Dr. Samantha. Dr. Samantha led our entire initiative when the CRO, we went there for the primary health care. His passion comes through. He actually constantly smiles in spite of everything. And I wonder, how he actually keeps that while he was handling 150 of us at the same time. The formal introduction to Dr. Ranasinghe is that he's the Director of Primary Care Services and the Director of Training, Ministry of Health, Sri Lanka. We happened to visit his training facility. Hugely impressive, both the college and that which has allied services. He's a board-certified consultant in medical administration and a specialist in the medical administration and public health. A visiting lecturer at the Faculty of Medicine, University of Colombo on PGD in health development. He's a researcher at heart and a propagator of health systems. Dr. Samantha's PPTs are usually something that give us a lot of thought. I look forward to having your address, Dr. Samantha. Thank you.
Thank you, Uma, and Dr. Reddy, Dr. Alpana Pitya, sir. And before I start my presentation, this is a model developed by Panapitya, sir. So I would like to invite him for just briefly tell about this structure.
No, actually, that during the induction of our college sessions and inaugurations, so then at the presentation, so then we developed this structure with all strategies included there, identified by the WHO framework. So it will give a good idea and directions how we could have achieved the resilience through all the strategies. I think Dr. Samantha will elaborate more on this and our health structure and other health services.
Okay, I'll come to my presentation. I think this has been presented in our forum in Sri Lanka. This is the first hospital built in the world. This is about 2,000 years back by King Pandukabaya from Sri Lanka. So it has all it's developed as a hospital where you have like toilets, the wards, and also this, you can see here, bathing, traditional medicine. So we run a long history of medicine in Sri Lanka. So, and before Alma-Ata Declaration, we started our new primary care settings. You can see this is first built in 1926 in Sri Lanka. So there we started our public health in 1926. And this is a brief description. So we have provinces, and then provinces is divided again to districts. We have 9 provinces and we have 25 districts. But that is administratively, but for the medical purpose, we divided into 26 districts. So each provinces have a provincial director of health services and also regional director of health services. That is the provincial setup. In 1988, this is devolved to provinces from the line ministry. So certain powers are delegated to the provinces, but certain powers are kept in the line ministry. Example, the financial, the tradings, and policy making is belongs to the central government. So, and also we have different health systems, mainly the allopathic system, but we have traditional medicine, Ayurvedic, Unani, Siddha, homeopathy, acupuncture. So most people go for Ayurvedic practice also. So we are not, I mean, when it's come to this primary care services, we sometimes ignore about the Ayurvedic practices. So if you, again, this health system is divided into line ministry and provincial, and then the preventive. Again, line ministry, each ministry is divided into preventive and curative. So this is a regional setup, regional provincial setup. You have the provincial minister of health and the provincial secretary and the provincial director and regional director. So for the preventive side, you can see the MOH, medical officers of health. Under him, you have the public health midwives and the PHIs, PHN, who do the preventive work. And you can see a public health midwife cycling. They go door to door on maternity and child care, healthcare especially. And they have to have the records, each and every mothers and children's records are there. So she has to visit, and in top of that, she was given other responsibility recently. And in the top of on your right hand side, you get the public health inspector, whose mainly is on food and drug control activities, foods and I think I lost the presentation. Can you see the presentation? Okay, and so that is the preventive side. And when it's come to curative health, there are curative health institutions. So, and these are the hospitals facilities that we have. We have tertiary care hospitals, secondary care, and primary care. Altogether, we have more than around 1,200 hospitals, but majority are in the primary care, where we have around 1,052 primary care institutions. Those also divided into type A, type B, and type C, and also primary medical care units. This is more focused on first contact of the people. So, and these divisional hospitals are divided according to bed facilities. So it has inward facilities, but we don't have consultants at this level. So these are again some hospital setup, and again these are some we have the primary care. So my topic is integration of different level of cares. So we have recently reviewed what we have done in the past, and then we thought what should we do in the future. So we all got together and we discussed that the first contact of care should be improved, and our objective is to achieve the universal health coverage and increase the primary healthcare usage. The primary healthcare usage in Sri Lanka, the OPD setup is good, but the inward facilities, especially when I mentioned the hospitals, the bed occupancy rate is very low. It's around less than 30 some hospitals. So it's sometimes waste of money, and people tend to bypass the secondary and tertiary care and giving the burden to that hospitals. So, and also we wanted to increase our primary care settings, and our goal is to have a good system with a good health system resilience. So these are some policy documents that focus on primary care. So these are some projects that we have done. I mean, from the donor agencies, World Bank, USAID, and ADB, and different directorates work in silos sometimes, together sometimes, especially NCD, Cancer Control Program. So we have vertical programs which trickle down from the tertiary care to primary care levels. So these are some donations from the projects. And now about integration. These are some major activities that we have defined. 10 activities we have found: establishing family clinics, strengthening the A&E, using the PMC as a step-down hospital, and strengthening for special needs children, elderly care, mental health, and community empowerment. Especially, we have started a caregiver program for the community, and also disaster preparedness for primary care, and capacity building for the medical officers, nursing officers, and other staff, and strengthening eye care. So I will go to this one. So the integration of different level of care. Now, if you see, this is a simple cluster. So we want to define a cluster. It could be a apex hospital, could be a teaching hospital, district general hospital, or base hospital. Around that, you can see these are divisional hospitals, which are primary care. So we want to link these two hospitals by referral and back referral systems, and resource sharing, and also by telemedicine, giving the consultations opinion for the primary care level from the apex hospital, sometimes visiting these hospital and back referring the patients as a step down hospital, especially for geriatric care and chronic illness people. So that is how we trying to integrate two levels, and also like making more attractive of primary care hospitals in Sri Lanka. So this is a bit a complex cluster system. So actually, some district they are piloting this cluster system, especially in the central area of our country, Anuradhapura. So they are doing that pilot. So we want to roll out this one, especially for like resource sharing, and also communicate with each level. So we don't want to be defined. We don't, although there's a definition for secondary tertiary care, but we want to integrate the system with the aim of like care pathways, patient care pathways. Example, if diabetic patients come to the primary care level, he could be different level. He could be having normal sugar level, so he might be having complications. So the normal people can be managed at the primary care level, but the complicated patient should be referred to the tertiary care or secondary care. And after managing them, so we'll take back to the primary care level. So that is a refer forward system as well as the back refer system. So those are in discussions, and we slowly putting efforts to do this, but it is a long journey. It's a start of a long journey. So, and also now we are looking for a software for patient record system where the system can do the refer forward and backward system. Luckily, we have found yesterday we had a great discussion. So that will be implemented where the patient can be registered in one place and he can be accessed from anywhere in the Sri Lanka. So so that part is solved. Now it's a matter of like rolling out in the country. And also we believe on the telemedicine. So actually thanks to USAID and Dr. Panapitiya sir. So we already distributed 230 smart boards, especially all the Apex hospitals are having. So we want to give the consultants services to the primary care through this telemedicine platform. Or there will be drawbacks. I mean, patient management is not like from the TV. There should be human touch, but we will not go into the provider to the user, but we will do the telemedicine provider to provider. That means from larger hospitals to the smaller hospital, where two doctors, the consultant and the doctors at the primary care, will be getting the opinion with the examination of the patients and their vitals at the primary care level. So, so we don't want to like go 100% telemedicine from provider to patient. So we do the capacity building, although the equipments are there, the infrastructure are there. We believe that continuous professional development, continuous education is vital. So we do some capacity building program, and this is done as a group work, as also individual. We have circulated the people who don't have any experience on certain areas. They can certainly come to the Apex Hospital and get training on that specialty. So these are some WHO funded programs that we have done. So this program is two-day program. This is not only training. During this 2-day work, we go to the province with our team, DG sir, the Panapitiya sir, and our respective directors. And then you can see on the right corner, below corner, we are having the discussion with the provincial directors and the regional directors. So we use this opportunity for monitor and evaluation and get the feedback. What are their requirements and what are the drawbacks they have and what facilities they need and how can we help. So this is not only a capacity building, but we use this opportunity to do the monitor and evaluation purpose. And achievements. This is from the forum. So we have started the telemedicine program and developed the 10 activities and also caregiver programs. So we see a bit tough, because now this is a cascade training. We do the trainers of training program, and after that the community people should get trained. So what we found the difficulty is how we can recruit the people from the community. So that is we are working on it, how to address it, and we want to get involved with the other sectors like the local government. So we are trying it to do it. So, and challenges, we have financial crisis, human resources, supply chain, and these are some slides from the PHC forum, and we need support from the GLP, and also we request the access to have our evaluate our strength of the health system with the tools that you have developed. So we looking forward to it, and also we would like to have some projects with Access International Health. Thank you, and thank you very much giving this opportunity. Thank you.
Thank you, Sri Lanka team. And thank you, Dr. Samantha, for elucidating and sharing with us the entire model of how the Sri Lankan system works and their health systems and the resilience and the activities that you have taken forward. I now open it up for a question and answers, and subsequent to that, then we will have our closing remarks. So please do share your questions.
Uma, while the questions are coming, I just wanted to congratulate the Sri Lanka team. I mean, this is a classic example of how we can learn rich learnings from the practitioners, because that's the on-ground practice, translating some of the high-level conceptual ideas into the real practice, because we keep talking about strengthening primary healthcare, integrate primary, secondary, tertiary healthcare, engaging community. But I think what Dr. Samantha has given a outline of the steps that they are taking is a classic example of the operationalizing and unpacking some of these conceptual frameworks. So thanks, Dr. Samantha, for that excellent exposition of the primary healthcare and community engagement. Yeah, we were, in fact, as a part of the GLC, it will be interesting to document some of the initiatives that Sri Lanka is taking in making the primary healthcare as one of the anchor in preparedness of the health systems. I think that's one case study that we can capture. And also, we will be more keen to learn and also share, I mean, what you are doing with the community engagement in improving their literacy. I think that is what is one of the initiatives that we are taking. So we'll be maybe waiting for the next event where you can share it as a case study, what exactly is happening in terms of this transformation. Just one question I have is specific to, I mean, while strengthening the primary health care, are you also integrating, like tomorrow, if there is a sudden demand for the healthcare services for any other pandemic-like situation or epidemic-like situation, there is a sudden demand of 5 times, 4 times increase in the demand. Are you designing this primary healthcare to face that sudden surge in the demand?
Panapite sir can give the answer. Yeah. The pandemic preparedness. It's about the pandemic preparedness, is it?
Yeah, actually that during the COVID time, so then it was so strange to us as for the others. So then at the beginning, so we initiated to develop isolation centers and develop the giving the awareness for the health staff and also to the public, how to actually prevent from getting infected. And also that develop isolated corners for the fever and suspected patients. And thereafter, and they were admitted to the isolation centers. It was actually started with 3 hospitals, and then thereafter, actually all around the country, increased up to 28 hospitals. And then thereafter, with the isolation, initial management, they will be transferred to, they have were transferred to the treatment hospitals. It started from 1, then increased up to 2, 3, and ultimately ended up with 10 hospitals. In the second wave, so then it was so that we identified it's not so harmful. And the most patients were asymptomatic patients, 80% of the patients. So then actually we didn't disturb to the main hospitals, and we identified the primary care institutions and developed as treatment centers. So then all the patients, they can come to the, in all the hospitals actually, we develop the screening centers and also isolation rooms. And thereafter, actually, that they were admitted to the primary health care institutions for the treatment. And in each and every area, so then mostly the division of hospitals, and then thereafter, when the patient load is increasing, then we converted some training institutes and other youth centers and other non-health institutions as intermediate care centers for the management of the patients. And at the end of the second wave, actually we developed around actually 45,000 beds for this purpose. And the second wave during that period, so then they had the time to actually spend the time with leisure activities even. And with the support of the other armed forces, so then they operated some isolation centers as well. And thereafter, in the third wave, so then it was so virulent, and the Delta wave, and thereafter other waves actually that is so virulent than the previous. So then we had to open. So with the huge influx of patients and due to the virulency, we opened all the patients, all the hospitals actually for the case management. And thereafter, previously, we informed all the provincial directors and regional directors to develop improve the bed capacity in their provinces as much as possible to cope up and cater their patients in their regions. And it was actually so helpful at the beginning of the third wave. But we couldn't bear all the patient load in those centers, and we opened all the major hospitals, even from one ward to one by one wards actually that were allocated for the COVID management. And ICUs were actually allocated for the COVID management, the dialysis centers. And we developed actually for the major cases actually were admitted to the major centers, and then the specialized centers for the surgical things and dialysis thing, and for the mental obstetric cases and other mental health patients actually that the separate centers were developed for the management of those special cases. And thereafter, actually, that one day, so then we had all the main hospital directors came to our office. Actually, then they complained they couldn't manage actually the huge such influx. So, and I discussed, and within half an hour, so I gave a solution to develop a screening facility at the OPD, so that screen patients if they are very in a critical situation, straight away admitted to the hospital and manage, and even to the allocated ICUs, and even to the other facilities. And other mild and moderate patients, actually they were sent to the step-down hospitals. That means actually affiliated primary healthcare institutions to the major hospitals, and they were managed with a simple oxygen therapy and with a normal mask and simple oxygen therapy. And other patients actually that were asymptomatic and very mild cases were sent to their homes, but entering into the home-based care system. Actually, it was a database developed actually software, and through a call center facility, they were managed well throughout the day. So then morning and evening, they were managed, and they were monitored by medical team, consultants, and also the from nursing officers, and also the medical officers, and even the consultants. And without any death, so then it was managed. We were able to manage those patients in the home-based facility. And a special thing actually that should be mentioned regarding the oxygen management, because actually there with the experience in the other countries, in the other world, so then we projected our oxygen requirement, and some 10 strategies actually we adopted for the oxygen management. So ultimately, actually, it was very successful. for the management of those critical patients. But anyway, that unfortunately, I want to mention one thing. So then our media, I think everywhere. So then it was the help, actually the support given by the media was so poor. Actually, they wanted to actually give the media messages for the media publicity, not for the actual case management. So all the COVID, even like other viral infections, so then the patient should be kept at rest and they should be hydrated. That's the only and main thing, except in the Delta virulent virus wave and the other cases. And then thereafter also we manage all the patients without a much very limited deaths in such a way. So they were keeping at their homes and even at the centers with a good rest and hydration. So then thereafter, actually they could without going into the silent hypoxic conditions, they could be managed without any harm and further deteriorate the conditions which need the sophisticated instruments and the equipments. That's a thing actually that what we have done. And with the innovative solutions, we could have managed the COVID incident, and that's experience actually. And that the interventions, the innovative interventions, also they are very correct. And this time also we could be actually manage. It could be continued for the management of the patient. So then, but lessons learned actually that is poor. So then we have forgotten those very good interventions. So then we straight away actually that went back to the status, maintaining the status quo. And I want to actually mention, so then we visited your conference, Global Learning Collaborative in India, Delhi. So, and we were so inspired actually. And that's why actually we developed our theme also in the college like that, rising through challenges and leading towards health system resilience beyond boundaries. Beyond boundaries mean actually that beyond geographical boundaries, beyond beyond the compartmentalization, collaborating with other sectors, other specialties, and everything actually is included there. And so we did many activities. This time doesn't permit anyway that we can't actually meet physically, but we can actually use the technology to meet frequently, and we will utilize the time, share our experiences in future. Thank you.
Anuradha, would you like to take on your question?
Sure. Thank you, sir. Good evening. Actually, the question was pertaining to one of the programs you spoke about, the telemedicine program. I think during the pandemic, many of the countries made significant strides into telemedicine, including India. And now there is a government-led program on telemedicine. Just wanted to understand, sir, how you have been using telemedicine for care continuum and strengthening of primary health care. Thank you, Uma.
So that is even during the COVID, we use the telemedicine. Actually, it's not like fully telemedicine, but home-based care. It could be named as a mobile medicine or something like that. So the continuum of care, what we are going to, So what we are going to do of continuum of care now, example at the primary care levels, the medical officers are there who's just MBBS doctor, but they are not specializing in particular area. But some of them are very senior, sometimes they are very, very good in clinical. So example, if you took a diabetic patient, so if if that particular patient is there, so you can get a consultation from the consultants at the Apex Hospital. So he can be referred. Example, if his creatinine level has gone up, he's going for a renal problem. So then definitely they get the opinion from the Apex, as well as he or she can be transferred to the Apex Hospital for renal management. So that is one. And if we take A&E services, the accidents may come or any kind of myocardial infarctions can come to the primary care level. So until before transferring or during the transferring, this telemedicine can be used. The patient's vitals can be shared with the consultant at the Apex Hospital, and also management what to do, and they can take the ECG and get the opinion. And during the transfer also they can use this telemedicine things for patient management, so that thereby when the patient reach at the Apex Hospital, he could be a stable patient. Otherwise, if the properly not managed, if you are not given the loading dose at the primary care level until he reach the secondary care or tertiary care, so the patient might die. So those are the ways that we are thinking of doing. And also, and back referral system as a one, as if they are a stroke patient, if so for the at the tertiary care level, he might be occupying that bed for a long time, but after initial management only he will be needed the rehabilitation like physiotherapy, just IV drugs, that's all. So that those people can back transfer to the primary care level and also get the telemedicine opinion. The patient is, your patient has transferred back here, and this is now his condition, what shall we do? So there's a linkage between the tertiary and the primary care level. So the continuum of care is there. That's how we are thinking of. So it's not an easy process. It's a very costly, not costly. I mean, it will take, like, we have to define the care pathways and we have to get together the multidisciplinary team. So it will take time, I suppose. So we have to start in somewhere. So I hope I have answered the question.
Thank you, sir.
So anybody for any more questions, or should
Hi,
we-
Uma, I have one question, if there's time.
Oh, yes.
I go on. It is such a pleasure to see my home country join the family. So very special for me today. I have one question. I'm actually the technical coordinator for climate and health in the GLC network. And so I operate at the Southeast Asian region, but I'm very curious to understand. I see that we have disaster preparedness as part of our approach, but in the larger context of climate preparedness, it may not necessarily be disaster related. There could be climate change as an impact that is a lot more slow at onset. So I would love to understand if Sri Lanka, we have put in place preparations within the healthcare system to address both long-term impacts of climate on communities and their health needs, and whether we are also planning for impact within the health services system at the primary healthcare level for these impacts, and whether we have continuity of care in the light of those things. Thank you.
Yeah, so for that, I have mentioned one slide, one point regarding the disaster management. So it includes the climate changes, exactly, floods, the natural disasters or something, those things. So at the top levels, I mean, at the secondary tertiary care, yes, there are training programs and preparedness at bigger hospitals. So we have separate specialty called diploma in disaster management. They are MBBS doctors and they specialize on disaster management. So we don't have a MD program, but they have to do some drills, and drills are done continuously. We have a separate disaster management unit, at the Ministry of Health. So those things are happening. But the lacking part is the preparation at the primary care level. So we have to give the training to them. So we are hoping to have a kind of a training for them, and also disaster preparedness. So it was discussed longly, and to have actually a scenario based learning, and also to prepare the closed hospitals for disasters. So that can be according to climate change or any other conditions, road traffic accident. Yes, you should more focus on the climate change. So we happy to collaborate with you, and how we can adapt to the primary care setting. Yes, I'm welcome. So that can be done. So we need help from you. Thank you.
And also that we have developed medical officers with a diploma for the disaster management, and they are attached to each and every hospital, and also the regional and provincial directors, health officers, and they have actually planned for the disaster, developed disaster plans for each and every hospital. But the climate change, especially, not so focused. But anyway, that we should actually give a thorough training for them also regarding that. You can help us actually at least to develop online training even. So
Yes.
then it will be worthwhile.
So that could be a higher card. I mean, since you're in regional area, so we can discuss on those areas. So we designed a comprehensive one, but sometimes it's missing some bits and pieces.
Yeah, regarding actually regarding the telemedicine, rather than telemedicine, actually I would like to mention telehealth. So then during the COVID time, so then we initiated to develop physical training programs for the health staff. But anyway, with the heavily spreading infection, so we couldn't have organize actually such physical training programs. So we use the telehealth system, actually teleconferencing system, to train each and every health personnel, and also the non-health personnel attached to the other offices and everywhere in the country, and like that. And regarding the telemedicine even, so this recently our consultants, one consultant anesthetist, he has actually vacated the hospital, the major hospital. So then the surgeons and VOGs were hopeless actually to what to do, and without having a consulting service, they couldn't do their surgical part. Okay, so then but the senior medical officers were there. They wanted to get some opinion from from a consultant, so then they can screen the patients screening can do, and they want to get some opinion for the complicated cases. So I actually asked them to initiate the teleconferencing thing for to get the opinion for the consultation from the high centers. That could be thing actually we can use for the telemedicine thing. We have with the help of the one project, so we have distributed many smart panels actually for the primary healthcare institutions, but halfway actually we have covered. There's a rest actually to be covered in future.
Should I close, Dr. Reddy?
Yes, I think we are in time. It was a great session.
Thank you, Dr. Satish, for being a continued part of our journey. And we always look forward to having you here. Dr. Manoj and you, Jack just dropped off. Many of us who Dr. Manoj. So it's always a privilege to be a part of these chapters. And I emphasize that every time I speak, because each country chapter has given us new areas of learning. And this one was about strengthening the primary healthcare system. The emphasis that they lay on primary healthcare in Sri Lanka is something that came through all the conversations that we've had so far. 1,200 plus hospitals, of which 1,052 are type A, B, and C in primary healthcare. That speaks volumes that people do need to go there while they still have problems in terms of converting them to stay there or use their inpatient services. Resilience, geopolitics, global warming have been their priority. And it is crisis and resilience is a part of Sri Lankan health systems. But I love the way Dr. Panapatya described it as being strange, the pandemic, and how they were skillful in facing both the civil law and the tsunami as they took forward. They have a number of health indicators already put out and have followed the WHO systems that have been laid out. But their emphasis on door-to-door services, multi-systems mixed approach for healthcare, response, adapting and transforming where necessary are some of the things that came out very strongly as part of the conversation. They looked at not just allopathy, but also other streams of medication to support the services as and when they were required. Delivering high quality care, ensuring social justice and equity as an outcome. Again, I will repeat, ensuring social justice and equity as an outcome is something that they're looking at. I think that is a wonderful way of providing that last mile care to the publics of Sri Lanka. They have reviewed their systems, come up with the universal health coverage as something that they would like to take forward, and using the PHC for the inpatient is something that they're looking forward to. Health systems resilience, which are tied down to primary care, is what they're looking at. And strategically, they have 10 areas covering the entire range of health systems as part of their activities. They have partnered globally and locally with many large multilateral and bilateral institutions. Defining a cluster is something that we thought was easy. No, but they showed us how clusters and linking them through referrals and resource sharing, telemedicine, and back referrals for step down is something that was again emphasized by Dr. Samantha. How do they make primary healthcare attractive? How can they look at packaging those care pathways that will actually take them down that road which they are looking at? Some of the areas that they have shared is something that we will definitely look forward as a case study. 230 smart ports and counting. But the emphasis of the human touch is something that they did not miss. Capacity building is yet another area that they are looking to strengthen. And I'm sure they will have the cascade training, recruiting of people from the community as they go forward. The answers to some of the questions and the importance of how they actually distributed during the strange times of the pandemic is something that was noteworthy. It's hard to encapsulate. That has been said and worked upon over years in 5 minutes. But as always, it's always something that we enjoy in terms of learning, in terms of collaborating, in terms of growing, and in terms of making sure that these streams that we have been outlined, these verticals that we are looking at, these areas that we will grow with each country chapter and share across the collaborative is something that we will take forward as we go. I'd like to say thank you again on behalf of everybody, this team, because I think we are all one family, and we have grown to be one over the last 2 years. A significant day. We are 15 years at Axis and the 3rd chapter at the GLC. I'd like to say thank you very much, and a good evening, morning, and night for people who have joined in.
Thank
We
you.
also want to actually that convey our sincere thanks actually joining with us this important event in initiating the Sri Lankan chapter of GLC. And so it will be so inspirational in future also that if we can meet frequently actually through teleconferencing, and also that if we can actually identify one area per day, like so then we can share our experiences, it will be worthwhile actually for every one of us. Thank you.
Thank you very much.
Everybody.